Let's go ahead and learn everything we need to know about hypertension for our Medsurg or adult health nursing course, and obviously to be prepared for the NCLEX. Hypertension is the number one most common chronic disease among adults in the United States. So this is something you're going to deal with all the time. Let's start with pathophysiology. We know that to increase our patient's blood pressure, we can cause vasoconstriction. Vasoconstriction is where the arteries get smaller, and that by default, that increases a patient's blood pressure. We do this all the time. When we have fight or flight, when we're exercising, one of the things the body does is it vasoconstricts to bring up our blood pressure. Chronic hypertension or a high blood pressure, what we're talking about today, is where a patient's blood pressure is chronically elevated. And most commonly, that's because their vessels are long term constricted. This is not by any means irreversible or permanent, but the fact is that the patient's blood vessels are on a regular basis, meaning all the time, the patient's blood vessels are constricted. And because they're constricted, their blood pressure is elevated all the time. That's the most common pathophysiology of hypertension. There are other ways that we can bring up a patient's blood pressure, but when a patient just has hypertension, the most common physiological reason for that, the patho of it, is that the patient's blood vessels constricted, and that's where they just are now on a regular basis, and that's what causes the patient to have a high blood pressure. Now, there's two reasons of why that can happen. In 90 to 95% of all people that have high blood pressure, hypertension, it's what's called primary or essential hypertension. In primary or essential hypertension, the patient has no underlying cause, nothing that caused this vasoconstriction. It just happened. It just developed over time. We could say it's part of aging. We could say it's part of lifestyle. We'll get to that in a little bit, but it just happened. There's no underlying cause. It just happened, and the patient's blood pressure is now chronically elevated. The second type of hypertension, which is much less common, 5 to 10% of all patients, is secondary hypertension, where it is related to an underlying cause. That underlying cause can be hyperthyroidism, it could be Cushing's, it could be certain medications like steroids, it could be kidney problems, and we'll talk about that in just a few minutes. Now, what are the signs and symptoms of a patient who has hypertension? Well, that's a tricky question because in the case of a patient who has chronic hypertension, meaning over from when they were 18 years old up until they became 30, 40, 50, 60, the blood pressure just slowly crept up, and now they're 60 years old and their baseline blood pressure is 155 over 90. So they have hypertension, but they're going to be completely asymptomatic because think about it. In the example I just gave you, the patient's blood pressure went up about 1 to 2 points per year. Of course, we're not going to notice that. We're not going to have any symptoms. Is it harmful and causing harm to the body? 100% yes. Do we need to treat it? 100% yes. But the patient's going to be asymptomatic. And the way you should teach that to the patient is that's a good thing. We want you to be asymptomatic. Once you become symptomatic, now we have problems. But what does symptomatic hypertension look like? Symptomatic hypertension is where a patient has high blood pressure and it happens suddenly, it happens acutely. The medical terminology here is hypertensive urgency or hypertensive emergency, and it's where the patient's blood pressure suddenly or rapidly increases to above 180, 190, 200 systolic, above 110, 120 diastolic. Those numbers, and I'm being very vague because it depends on whether you're talking hypertensive urgency or emergency, and it depends what guideline you're looking at, but those numbers constitute hypertensive urgency or hypertensive emergency. In those cases, we do expect a patient to have symptomology. And in fact, part of the diagnostic criteria for those two conditions, hypertensive urgency and hypertensive emergency, is where not only is the blood pressure elevated, but it's elevated plus the patient has some signs or symptoms. What signs or symptoms would those be? The classic ones there would be a headache or blurry vision. Those would be the most commonly tested on symptoms of hypertension. Nosebleeds is also something that can happen in both acute and chronic hypertension. The diagnostics of hypertension is very simple. It's checking a blood pressure. To officially be diagnosed with hypertension, a patient has to have a systolic greater than 130 or a diastolic greater than 80 on two or more blood pressure readings. Now, I'm not going to get too deep into this, but we do usually count home blood pressure readings as part of that diagnostic because of what's called white coat syndrome. White coat syndrome is estimated to affect at least a quarter of the population, and that's where a patient's blood pressure is elevated in the medical setting when they're in the urgent care or in the doctor's office or in the hospital, but it's actually normal at home or at least significantly lower at home. Because of that, we do often use home blood pressure readings, assuming we teach the patient how to take it reliably, to use that in the management, in the monitoring, and even in the diagnosis of hypertension. How do we assess a patient for hypertension? Well, this isn't going to be your usual assessment. Over here, we're going to assess for the risk factors of hypertension because most of these are also going to be in the client education box of how to reverse hypertension. But let's look at the risk factors. The risk factors are lifestyle, so that's going to be someone who doesn't have a healthy diet and someone who doesn't get a lot of exercise. Smoking is a tremendous risk factor for hypertension. Every single cigarette, we're talking about tobacco cigarettes, those do increase your blood pressure. Caffeine absolutely increases your blood pressure. Elevated weight and obesity absolutely increase your blood pressure. And stress increases your blood pressure. Excessive salt intake increases your blood pressure. Now, all of those are what's called modifiable risk factors, meaning those are going to be part of our treatment plan to target to lower a patient's blood pressure. Then we also have or non-modifiable risk factors, and that includes family history, ethnicity, and the patient's age. Now, the underlying cause, we've already talked about this, so you're going to assess for these as well, because these might be reversible, and if these are what's causing the patient's high blood pressure, if they're in that 5 to 10% of the population that has high blood pressure because of an underlying cause, we absolutely need to fix the underlying cause in order to fix their hypertension. And like I said, those can be kidney problems, Cushing's problems, thyroid, and certain medications like steroids. Your nursing priority is going to be to address modifiable risk factors. That's going to be the number one thing that you can target as an RN. And that's going to be very commonly tested on with hypertension. So what does that include? Let's look down at the client education box. That includes educating the patient about the DASH diet. That's the diet that was developed, I don't know exactly by who, but it's popularly promoted by the AHA. And I have a picture of it down here on the slide. And that is what we want to recommend to all patients in order to help reduce their hypertension through their diet. And this can be by reducing fatty meats, reducing full fat dairy, reducing sweet, and reducing salt in a patient's diet. Now, other modifiable risk factors and other client education, and this also falls in the treatment box, that first line, that lifestyle modification. So let's finish this list. We want to get the patient to increase exercise, and the AHA recommends 30 minutes a day, 5 days a week minimum of aerobic exercise, meaning where you get the heart rate up. We also want to recommend that the patient lose weight if they're at an elevated BMI. We want to recommend they quit smoking if they are a smoker. We want to recommend they do stress if they have stress that could be contributing to hypertension, which is probably most people. We want to recommend they reduce alcohol if they're using alcohol in excess. And we want to recommend that they improve sleep. Each of those are considered therapeutic or non-pharmacological interventions for the treatment of hypertension. All of those are going to be things that you're going to be able to recommend as a nurse, and all of those are very much tested on in both the NCLEX and your nursing school. Let's get back to treatment. So treatment is going to be lifestyle modifications. That's going to be what we just talked about that you're going to recommend to your patient. If we are doing medications, which we are almost always going to be doing both, then we are going to move on to the following medications. All patients that are diagnosed with high blood pressure, or nearly all patients, are going to be started on one of 4 different drug classes, and possibly they could be started on 2 or more right away. In most cases, if we catch the patient at the 130s, or not 130s, we don't usually start medication in the systolic of 130s. It's usually the guidelines say we start medication in the 140s, 150s systolic. But if we are going to be starting medication, we are going to first of all have a target of getting their blood pressure down under 130. We're not usually trying to get it under 120. If it does happen, that's great. But our target is going to be get the systolic down under 130, the diastolic down depending on what guideline you look at, below 90 or below 80. Now, again, what medications are we using? There's 4 first-line drug classes, and you probably should know this for testing. And those are the thiazide diuretics, such as hydrochlorothiazide. They are the ACEs and the ARBs. ACEs are angiotensin angiotensin converting enzyme inhibitors, and that's going to be your prils, the Cinepril, Captopril, and Elapril. The number one most common thing to know about those drugs is A, they're teratogenic, and B, they can cause a cough. Next of the 4 drug classes are going to be the ARBs, the angiotensin receptor blockers. Those are going to be the Artins, losartan, irbesartan, things like that. And the most common thing, again, tested on that is those are also teratogenic. They cannot be given with the ACEs because ACEs and ARBs are essentially the exact same thing. The biggest difference is that ACEs cause a cough, very commonly. That's the number one most common side effect, and ARBs do not. And finally, the last of the 4 first-line drug classes, in addition to the thiazide diuretics, the ACEs and the ARBs, is going to be the calcium channel blockers, such as amlodipine. Amlodipine, the most commonly tested on thing about that one is that it causes peripheral edema. That's a very common side effect. In fact, that's the number one reason why we have to stop giving it in some patients. Those would be your go-to drugs. We do have some backup options or some specific cases where we would go to these options. And the other options would be things like beta blockers, things like alpha blockers. Beta blockers would be your metoprolol, things like that. Alpha blockers would be your alpha-zocin and drugs like that. We do even have some more backup options, things such as clonidine and methyl-dopa that I'm not even going to get into. That's covered in detail in pharmacology. Generally speaking, when we put a patient on medication for hypertension, you do want to educate the patient that they're most likely going to be on this for the rest of their life, because even if their blood pressure comes down to normal, that's great, but that's the medication that got them down to normal, and it's unlikely that they're going to come off. Can a patient come off these medications? Absolutely. Is it common? No, it is not. How does a patient do it? If they really go and they target hard those lifestyle modifications and they really improve their lifestyle and they make those changes, then yes, it is absolutely possible to come off of these medications. But again, prepare the patient that in most cases, it's not going to happen, and that's okay too. If it takes medication, that's fine. If it takes non-medication options to get the blood pressure down, that's fine. We just have to get the blood pressure down, whatever it takes. And finally, the last box, the complications that can arise out of hypertension, and primarily this is uncontrolled hypertension. And the scary thing is, if patients don't take their medication, the blood pressure is just going to go up and up, and the majority of patients are going to end up with these complications if they don't take care of their hypertension. Uncontrolled hypertension is among the leading causes of having a heart attack, of having a stroke, of having chronic kidney problems, of having heart disease and arterial sclerosis. So there's a lot of different complications that high blood pressure can cause. But again, it is treatable. We just have to make sure the patient's following their lifestyle modifications and or following the medications that have been prescribed. Hopefully this covers everything you need to know about hypertension. Hope you do great in class on the NCLEX, and we'll see you in the next video.